All right, let's get straight to it. Welcome to this high-stakes explainer on transfusion reactions. As a clinical consultant, I can tell you right now that when a transfusion goes wrong, the patient's deterioration is rapid, it is complex, and it is entirely unforgiving. So we're skipping the fluff today. We are jumping straight into the strictly calibrated mechanisms, the key markers, and the discrete management steps you absolutely must master to navigate these clinical emergencies flawlessly.
Our clinical timeline matrix for today is broken down into 4 critical segments. 1. The immediate catastrophe. 2. The acute hemolytic wreck. 3. The pulmonary floods. And 4. The master case. Let's dive in.
Section 1. The immediate catastrophe. Anaphylactic shock.
Picture this. You've got a young woman, and just 2 minutes after the initiation of packed red blood cells, she experiences a catastrophic drop in blood pressure. We're talking down to 65/30, alongside acutely increased airway resistance. This incredibly rapid onset is the absolute signature of a type 1 hypersensitivity reaction. Literally, the absolute moment donor blood containing even trace amounts of IgA is infused, it triggers massive, systemic mast cell and basophil degranulation. The clinical signature here is undeniable: sudden onset, profound shock, severe wheezing, and angioedema.
So why does this happen? Well, it brilliantly illustrates the underlying IgA deficiency matrix. The pathophysiology here is strict. The recipient actually has a congenital immunodeficiency. They completely lack IgA. Because of this, their immune system recognizes foreign IgA as a massive threat and has already formed circulating IgG anti-IgA antibodies. When that donor blood hits their circulation, the antigen-antibody cross-linking is instantaneous. You absolutely must recognize this strict clinical signature of sudden onset shock, severe wheezing, and angioedema within this extremely tight timeline of just seconds to minutes.
Look, when this happens, you have an absolute medical mandate for management. First things first, stop the transfusion immediately. The strictly mandated life-saving therapy here is intramuscular epinephrine to rapidly reverse that profound vasodilation and bronchospasm. Sure, antihistamines and glucocorticoids are supportive, but epinephrine is your priority. And moving forward, future transfusions for this specific patient must strictly utilize washed red blood cells. That completely removes any residual plasma proteins, including that highly dangerous IgA.
Moving on to Section 2, the acute hemolytic wreck, ABO incompatibility.
Now we're shifting to the minute to 1 hour window, often driven by a clerical error. The pathophysiological trigger here is a devastating immune mismatch. You have preformed recipient IgM antibodies violently attacking the foreign ABO antigens on the donor erythrocytes. And because IgM is incredibly efficient at activating the complement cascade, this drives massive, rapid, catastrophic intravascular hemolysis. Those donor red blood cells are literally bursting open right within the recipient's blood vessels.
Recognizing this wreck requires strict attention to the diagnostic markers. The absolute clinical signature is a triad. You'll see the rapid onset of fever, severe flank or back pain, and hemoglobinuria, which presents as strikingly dark or pink urine. If you don't intercept this immediately, the free hemoglobin and massive inflammatory response rapidly progress to disseminated intravascular coagulation, or DIC. You'll see oozing from IV sites and acute tubular necrosis, leading straight to acute renal failure.
So, what's your move? The high-contrast medical mandate for the acute hemolytic wreck is distinct from anaphylaxis. Yes, you immediately stop the transfusion, for sure, but the very next critical step is aggressive IV fluid hydration. You have got to maintain excellent urine output to physically flush that free hemoglobin and toxic cellular debris straight through the kidneys, which prevents acute tubular necrosis and acute renal failure.
Section 3, the pulmonary floods, trolley versus taco.
Okay, let's look at the 1 to 6 hour window. A patient developing severe respiratory distress in this time frame generally has one of 2 primary conditions. The first is trolley, or transfusion-related acute lung injury. This is an immune-mediated capillary leak. Donor anti-leukocyte antibodies attack recipient neutrophils right in the pulmonary vasculature, causing massive, non-cardiogenic pulmonary edema. Contrast this with TACO, transfusion-associated circulatory overload. This is simply a hydrostatic volume overload in a susceptible patient, like someone with underlying severe heart failure, and it drives cardiogenic pulmonary edema. When we compare these 2 directly in a clinical variance box, note that both conditions present with bilateral pulmonary infiltrates within that 1 to 6 hour window. But look at the divergence in hemodynamics. It's night and day. Trally presents with hypotension, fever, a strictly normal ejection fraction, and a normal BMP. Taco, on the other hand, presents with hypertension, severe jugular venous distension, a decreased ejection fraction, and a massively elevated BMP. Because of this, the management mandates are violently different. Trally requires supportive care and mechanical ventilation, while Taco strictly requires aggressive offloading with IV loop diuretics.
Finally, Section 4, the master case, integration and application.
Let's test this with a high-stakes patient profile. You have a 22-year-old female receiving her first packed RBC transfusion for severe anemia. Within just 5 minutes, she develops sudden severe dyspnea, widespread urticaria, stridor, and her blood pressure plummets to 70/40. Now note the diagnostic trap carefully embedded right here: a slight temperature elevation of 38.2 degrees Celsius and a complaint of generalized back discomfort. These markers are strategically placed to aggressively tempt you into diagnosing an acute hemolytic reaction and rushing to order aggressive IV fluids.
But we aren't going to fall for that. We must execute a strict diagnostic sequence. Step 1, recognize the timeline. We are at exactly 5 minutes. Step 2, identify the strict anaphylactic signature. The profound hypotension, urticaria, and stridor represent immediate IgE-mediated or mast cell degranulation events. Step 3, actively bypass the hemolytic pathway. While fever and back pain definitely can be seen in hemolytic reactions, the ultra-fast timeline and the presence of severe airway compromise, the stridor and urticaria, override this completely. Aggressive IV fluids would be the completely wrong primary move here. This patient desperately needs epinephrine. Which brings us to Step 4. The correct underlying pathophysiology must point to the hidden immunodeficiency.
Let's exhaustively break down the exact option matrix you'd face. Option A, recipient IgM attacking donor RBCs. Well, that's an acute hemolytic reaction. It causes back pain and fever, sure, but not urticaria or stridor, making it incorrect. Option B, donor anti-leukocyte antibodies attacking recipient neutrophils. That's Trally. It causes hypoxemia, but happens hours later, not at 5 minutes. Option C, hydrostatic overload. That's Taco. It causes hypertension, not profound shock. Option E, cytokine release from donor leukocytes. This is a febrile, non-hemolytic transfusion reaction. It causes fever and chills, but absolutely no shock or respiratory collapse. This proves exactly why option D is the only correct pathophysiological mechanism. Recipient anti-IgA antibodies attacking donor IgA. This directly triggers the massive anaphylaxis responsible for the stridor, urticaria, and shock at that critical 5-minute mark.
As we close this explainer, I want you to remember this rigorous mental model. In the crucible of a clinical crisis, time and strict pathophysiological markers are your only true diagnostic anchors. By mastering this chronological matrix, you strip away the confusion of overlapping symptoms and you isolate the exact pathophysiological mechanism. When the next catastrophe strikes, where will you anchor your diagnosis? Trust the timeline, trust the strict markers, and keep pushing your clinical knowledge to the absolute limit.